Swansea Bay University Health Board. Mark.
Oh, thank you. Thanks. And I'd just start by thanking the organizer who invited me to come to this. I'm a medical oncologist. I don't have a particularly strong mathematical background, and this is a really great opportunity to me to interact with yourselves and maybe to help me to solve some of the problems that we encounter in practice. And when I see a patient to treat them, there are essentially kind of three factors. There's the patient themselves, and that's sort of biological factors like their age, their comorbidities, other conditions they might have, their general fitness for treatment, and their wishes as well. What's important then, what they want to focus on, what outcomes do they want from the treatment. We have information about the cancer from various sources. So we have imaging, typically CT scans or PET scans. We have the histology, we have genetics, we have genomics. And all this information is imperfect, it's imprecise, and some of it's missing, and some of it's inaccurate. And then we have information about the drug, and we generally derive from some clinical trial data, and that's done on a very selected population in a very controlled manner. It's very useful data, but the problem is then we have to generalize that to the bigger population that we treat in practice. And this is what we do generally. 20 years ago, that's all we did. Now, this is probably what we do most of the time, but we are a bit more sophisticated in the way we treat people. But we tend to treat to maximum tolerated dose protocols. So we give as much treatment as we can. And we treat people until the disease progresses, or until they have an unacceptable level of toxic effects, or until the patient says, for us to stop. And the treatment's based on clinical trial data. And the kind of things, as a clinician, I focus on is the efficacy of the drug. So what kind of professional survival do we expect? What overall survival do we expect? And equally important is what toxicity would we expect from the drug. So one of the things we tell the junior doctors who are training with us as well, it's a bit of a true cliche, I suppose, but we treat the patient, not the tumor. So it doesn't matter if we shrink the tumor by 20 or 30%. If we've given the patient such debilitating side effects that their life is completely miserable. So the toxicity to me, is just as important as the efficacy of the drug. And now we give maximum tolerated dose, so as much dose drug as we can, until that patient can't tolerate it anymore. And the dose is kind of derived from clinical trial data. So we know if we take a clinical trial, we know what dose we can give it to people where we get an acceptable trade-off between toxicity and effect. And I suppose over the last 15 years, yourselves, colleagues in mathematics, mathematical modeling have advocated a different approach to treatment, adaptive therapy. And this is one definition of a dynamic treatment protocol, but updates or adapts treatment decisions in anticipation of evolving tumor dynamics. And one of the criticisms of the way we can treat patients at the moment, or tumors at the moment, is we know that cancer is an evolutionary process. We know it's an ecological process. But we take very little account of that in planning the treatment decisions. And particularly maximum tolerated dose therapy is based on imaging generally or biochemical parameters, and we don't adapt it. And these are kind of the principles which probably underlie most of the theories of adaptive therapy, where we're going to change the dose, anticipating what's going on in the tumor. And one of the kind of tenets of it is that the resistance has a cost. So cancer cells become resistant to treatment. Some cells are more resistant to treatment than others. And resistance, well, but resistance of cost, it means there's a cost involved with becoming resistant. So one of the classic ways to do that, cells become resistant because they upregulate pumps on the cell membrane surface, which pump out the cytotoxic drug. And that requires a lot of energy. And so in the presence of the drug, that cell has an advantage because it can pump the drugs out. But in the absence of a drug, that cell has a disadvantage because now it's expending energy for no real gain. The next kind of tenet of it is that resistant cells can be suppressed by competition with sensitive cells. And so in the absence of the drug, the sensitive cells will have a disadvantage. So they can suppress the resistant cells. Therapy reduces the population of sensitive cells, by definition, they're sensitive to the drug. And then I'm just going to summarize that. In the absence of a drug, sensitive cells have a disadvantage. In the presence of the drug, resistance cells with a fitness advantage. And by modulating that, by changing the way you're exposing the cells to the dose, to the drug, you can take advantage of these two different fitnesses advantages and use competition between the cells as a kind of therapeutic strategy to benefit the patient. And so this just kind of to summarize it. The top is what we do at the moment. So you have the sort of purple cells are sensitive, the green cells are resistant. What we do at the moment, we give maximum tolerated dose of much chemotherapy, or whatever drug it is, as we can, and we eliminate all the sensitive cells, and we leave behind a population of resistant cells. And when we do this imaging, so we give a drug, we get rid of the sensitive cells, and the tumor appears to shrink down. So we do a CT scan, and the tumor has shrunk down, maybe shrunk down by 30, 40, 50, 60%. And we think to ourselves, fantastic, this is great. Let's carry on. We carry on, we push on, give more treatment, more, and these drugs are toxic and expensive. We give more and more treatment. And at some point, the CT scan will have shown the cancer's now progressed, got bigger in size. And at that point, we stop the treatment. But it's actually worse than that, because what we've done effectively is select for a population of resistant cells. So if we did re-challenge that cancer now with this drug, then we'll get very, very little response. And again, it's even worse than that, because some of these resistance mechanisms are not specific to a particular drug. So if you upregulate your cell membrane pumps, you're pumping out all the cytotoxic drugs. So if you re-challenge with another chemotherapy drug, you may get cross-resistance to it. So treatment in the metastatic setting fails because of resistance to the drug. So the adaptive therapy approach takes advantage of the competition. You give a drug, you eliminate the proportion of the sensitive cells, but then you either stop or reduce the dose, allow the resistant cells to grow again, and take advantage of this kind of competition between the two, and you stop the drug at that point. So that's adaptive therapy. And this is just a summary of sort of the dosing strategies of both of them. So maximum tolerated dose, high dose, and we kind of limited our toxic side effects. When adaptive therapy, we can alter the dose in response to the tumor, trying to take advantage of the competition between sensitive and resistant cells. And we can do this two ways. We could dose skipping, so we could drug treatment holiday, stop the drug for a period of time, then restart. And we need some kind of decision rule. So for example, if the tumor shrinks by 50%, we'll stop, and then we'll restart again when it increases in size. Or we could do dose modulation where we alter the dose. So we're not just completely stopping the drug and restarting, we'll just alter the dose depending on tumor response. And of course, you could do a mixture of these treatment strategies. So yourselves and other colleagues in the sort of in mathematical modeling have constructed really, really good, interesting models of adaptive therapy, and they kind of, you need to kind of model the tumor growth. You need some way of capturing the competition. You need some way of capturing the sensitivity of the drug. You need some way of capturing the cost of resistance. You need to capture the dose effect, and you need a decision rule about dosing. And so, pointer. This is one. So this is taken from the paper of Gallagher, and this is just one way of capturing the probability of cell death. And he's got kind of two components to it. You've got the sensitivity of the cells, and then you've also got this bit here, which is the sort of derived from the Hill equation, which is a way of constructing a sigmoidal dose response curve. And this kind of gives you a sort of sensitivity, takes into account the sensitivity of the cells and the dose of the drug that you're giving. And then you need some kind of decision rule, because you need to decide when you're going to start the drug or when you're going to stop it. So again, this is one example of a decision rule. I mean, lots of different decision rules you could apply. So here is, well, if you're going to treat, what dose are you going to give the cells, the tumor? So if the number of cells is decreased by 50%, you don't treat at all. If it's increased by a certain amount, then you increase the drug by a certain amount. If the number of cells have decreased by a certain amount, you decrease the dose by a certain amount. And then if that's not true, you just carry on with the standard dose. So you've got some kind of dosing rule there where you kind of link the dose you give to number of cells in tumor, or the size of the tumor, or whatever other parameter you're kind of using to assess how that tumor is responding. So the problem is that doesn't take into account toxicity at all. So that's a very fixed dosing schedule. And there are clinical trials of adaptive therapy. And one of the problems I can imagine is that you're not taking into account toxicity because in real practice, toxicity is a major problem. And probably most of my time is spent managing the toxicity of treatments rather than deciding what treatments to give. And it's going to interfere with the dosing schedule, because if you're changing the dose purely on the size of the tumor, how do you factor in, well, I can't maybe not be able to do that because the toxicity from the patient experiencing. So I was wondering, well, can we think about that? How can we factor in the toxicity, and how can we try and work out what effect that will have on the application of these dose rules? And so this is just a general slide showing how the relationship between toxicity and dose and therapeutic effect. So on the bottom here, you have increasing dose, and here you've got the response of the individual patient. And so typically you'd have a sigmoidal dose response curve. So increasing the dose will lead to increasing treatment effect, but also increasing the dose leads to increasing toxic effect. And then you have this range of doses here, the therapeutic window. And if you use those doses, you'll get an acceptable treatment effect, and you'll also get acceptable toxicity. So this gives you kind of the range of doses you want to be using in the patient. So it starts then getting quite complicated because dose influences toxicity. So the previous curve kind of shows that increasing dose increases the amount of toxic effect. But toxicity also influences dose, because you can change the dose in response to toxicity. And dose influences response. Again, the previous curve shows there's a relationship between the dose and the response. And the other important thing is coming back to what I said at the beginning, toxicity is a really important outcome. So toxicity isn't just a rule to decide on the dose. It's really important. It's an outcome for the patient, because and depending on the clinical context, if you're treating somebody with curative intent, you may accept a much higher amount of toxicity rather than somebody who's treated with palliative intent. And most metastatic tumors, sadly, still are treated with palliative intent. We're trying to control the tumor for as long as we can while maintaining the patient's quality of life. And so toxicity is really important, because if we're making that patient's life miserable, are we really achieving what we set out to do? And then the other thing that's important is cost effectiveness. We've limited resources. We have to use the resources the best way we can. Dose, response, toxicity all affect kind of cost effectiveness analysis. So when you manage toxicity, what can we do? If it's low-grade toxicity, we can just carry on, give the same dose. We can carry on and we can reduce the dose. We can withhold and then restart in some point in the future at the same dose. We can withhold the treatment and then restart at a reduced dose, or we can just permanently discontinue the drug. And we need, in terms of the characteristics of the toxicity, we need to think about the severity of it. How bad is this? Is it life-threatening? Is it mild? Is it somewhere in between? Duration, is this something that just happens for a few days, or is this going to carry on for months and months and months? The frequency, is this patient experiencing toxicity every cycle of your treatment? They have 2 weeks of really bad toxicity, or does it just happens once a week, once a year? And what's the risk of recurrence? If somebody has a life-threatening toxicity, is it safe to treat that patient again? Can we risk giving that patient the same drug again, or do we have to say we have to stop? And so we need, in particular clinical trials, we need some way of agreeing how we're going to define the severity of an adverse event. And we generally use the common terminology criteria of adverse events. And so grade 1 is going to be something very, very mild, not particularly clinically significant. Grade 2, start increasing toxicity. Grade 3, we're getting to the point where we're going to start getting concerned about this, because grade 3 generally is going to need some kind of medical intervention, may require hospitalization, where it's not immediately life-threatening. Well, grade 4 has life-threatening consequences and urgent intervention. And then grade 5 would be lethal consequences. And so this is pneumonitis. This is an example to show how it works. Pneumonitis is inflammation of the lung. So grade 1 pneumonitis, it's asymptomatic. Maybe we pick it up incidentally in some kind of imaging, and arguably we don't need to treat it, but probably we are treating more aggressively than we used to. Grade 2 will be symptomatic. So somebody will be short of breath, bit of a cough, they'd have imaging findings. We need to treat them, but the treatment can be done as an outpatient, maybe given a course of steroids, not particularly intense. Grade 3, severe toxicity now, so now we need to give them oxygen therapy, probably need to remit them, need to give them high-dose steroids. And then grade 4, starting to get into life-threatening toxicity, we can have to go to ITU for respiratory support. And so I just wanted to finish off by giving some kind of real world kind of data to kind of just show you what kind of drug, what kind of doses you get. And it's really dependent on the drug. And when I started 20 years ago doing this, chemotherapy was basically all we had in terms of type of drugs. And the side effects were neutropenic sepsis and alopecia, nausea and vomiting, relatively limited number of side effects. Now we have massive amount of new drugs. Almost every week a new drug is coming on. We have chemotherapy, targeted agents, immunotherapy, viral therapy, CAR T therapy, and the spectrum of side effects has become massively elevated, and it's made it much more complicated to treat the patients. And so alpelisib is that's what you call a targeted agent. It's a PIK3CA inhibitor. So PIK3CA, very commonly mutated pathway in cancer. There's multiple effects in cell biology, but one of the effects it has, it alters glucose metabolism, and that's important when it comes to the side effects from it. Now it's used second-line treatment for ER-positive, HER2-negative breast cancer. So that's a very big population group we're treating with this. But 40% of the patients will have a PIK3CA mutation. So a big group of people we're treating. And it's given in combination with an injection of a drug called fulvestrant. And then current way to treat it will again we'll treat until disease progression, unacceptable side effects, so the patient wants us to stop. And this is just a way of looking at the outcome measures for the drugs. Is looking at progression-free survival, the Kaplan-Meier curve. And it just shows that there's a benefit of giving alpelisib in terms of progression-free survival in combination with fulvestrant. And it's just another way of looking at it. It's looking at response. So that was before was looking at progression-free survival time in terms of months. This is looking at response, looking at how much of the tumor actually sinks down on imaging, and then applying something called a RECIST criteria to kind of make a standardized assessment of that. So those are kind of very typical outcome measures looking at the efficacy of the drug. But this is the other bit which is equally important, and that's the toxicity from it. And if the PIK3CA regulates cell metabolism of glucose, so you can see that 63% of patients who received that drug, this is the placebo arm, this is the people with active drug, 63% of them had hypoglycemia, high blood sugar. Sorry about that. And then, importantly, nearly a third of them had grade 3, and quite high of them had grade 4 life-threatening. So that's a lot of people having hypoglycemia, and that's a real problem in clinic practice because that's quite challenging to manage in terms of it's quite resource-intensive to manage, and it's a big chunk of people we treat. And so it's a lot of people having lots and lots of side effects. But you can see nearly 60% of this group will have diarrhea, 40%, 45% will have nausea, decreased appetite, third of them, rash in about a third of them, vomiting, fatigue. So it's a very toxic. It's a very toxic drug in the sense that lots of people will experience toxic side effects, which are difficult to manage. If you don't manage them appropriately, can be life-threatening. So you have to be very, very careful when you're managing people on the drug. And this is another way of looking at the kind of the effects of toxicity of it. And it's just this picture. You can see that 74% of patients had a dose interruption. So at least one dose interruption. Most of those dose interruptions were caused by the toxicity, and 64% of patients had dose reduction. Again, most of it was caused by toxicity. So you've got a toxic drug, you've got very frequent side effects, and the patients are having to take lots of breaks in the treatment, and they're having to reduce the dose of a drug quite often. And these are the kind of the rules you apply, and this one starts getting quite complicated because depending on the grade of severity, you can either carry on as you are, you can carry on and add an anti-diabetes drug, but you have to reduce the dose down one level if it doesn't resolve. Grade 3, more severe, again, you start to, so right here you could carry on, here you have to interrupt the treatment, and if it doesn't resolve promptly, you have to reduce that, if it does resolve promptly, you reduce to one dose level. If it doesn't resolve promptly, you have to permanently discontinue the drug. And then again, grade 4, more severe, again, add the diabetes treatment, but more stringent rules about reducing the dose. And so the effect is, these patients are having very common toxicities, and you're applying this a lot. So you're doing a lot of dose reductions, you're doing lots of people having gaps in time off the drug. And this just shows, vis-a-vis dosing options, you have your 3 levels. So that's the highest, you go down 1, you go down again, and then you stop if you go down below that. So this is my kind of question. Then one of the first questions, well, how do you incorporate toxicity into models of adaptive therapy? And assuming you can do that, what is the effect then of toxicity on adaptive therapy? Because if you're having to modulate the dose all the time, or not all the time, but frequently, and reducing the dose, you can't follow your dosing rules for the adaptive therapy. And so does that have a significant then consequence on the tumor's behavior? But the flip side of that is what the effect of adaptive therapy on toxicity, because one of the advantages of adaptive therapy is you're giving probably a lower dose to the patient because you're having breaks and reducing the dose and response rather than just carrying on the maximum tolerated dose. So you actually might end up with less toxicity from it. And because of that, that might have the counter effect on the response. And the other question is, what drug toxicity profile favors adaptive therapy? So what would alpelisib, if that's having lots and lots of treatment reductions and breaks, would that be the kind of drug which is good for adaptive therapy or bad for adaptive therapy? Would the drug where you have less frequent toxicities, but really, really significant life-threatening ones, like some of the antibody drug conjugates, is that the drug which would be better for adaptive therapy, or would that be better to carry on a maximum tolerated dose? And I suppose, bearing all of that in mind, then how can you optimize the relationship between response toxicity and dose and adaptive therapy? So those are my questions. So thank you.
Thank you.